So welcome to the Population Studies Colloquium. It's a pleasure for me to introduce to you Raul Santalaeulalia Lopez. Raul is the Beatriz Galindo Senior Research Professor in Economics at the Universidad Autónoma de Barcelona. He's also an affiliate professor at the Barcelona School of Economics and a research fellow at CEPR. He previously held an assistant professor position at Washington University in St. Louis, and is a research fellow at the Federal Reserve Bank of St. Louis and the Institute of Public Health at Washington University in St. Louis. Raul is well known to the economics department, the population center. He actually received his PhD in economics from the University of Pennsylvania, and whenever he comes to the US, he goes and makes the effort to stop here and visit the economics department and the population center. His background is in quantitative macroeconomics, focusing on economic growth and macroeconomic development. Within this broad interest, he is especially focusing on the connection between intellectual property, the macroeconomy, and inequality. Another line of research is the relationship between social insurance, resource allocation, and economic growth. He's conducting field work on this topic in southern Malawi. He has a long-standing interest in the determinants of the HIV epidemic and how they shape economic development in sub-Saharan Africa. We're very pleased that today he's going to share with us his research on infertility. So please welcome Raul Santalaeulalia Lopez.
Thanks so much, Emilio, for such a nice introduction. So thanks for coming. Thanks for inviting. This is a project that we have had for quite some time, a little bit in the back burner, but we are rebooting it. So I think it's a good opportunity to get feedback. So this is work with Fanny Groes, Copenhagen Business School, Anna Hostega in Serge, Daniela in Bologna, Magnin in WashU, and myself. Since the beginning of the project, we have witnessed 9 babies out of the co-authors. 2 of them through IVF, 100% success, okay? But it's not always the case, so let's see. So this is Denmark. I'm gonna be focusing on Denmark, administrative data. This is the fraction of, take a year, denominator is the total number of children born in a given year, births. The numerator is the number of children that are born through IVF. So you can see numbers, rising from 1.5 in the mid-90s, going up to 2009, which is the data that we have, 5%. If you look at the numbers right now, the number is going to be closer to 10%. So it seems to be a relentless trend in the amount of IVF technology that at least Danish are using. Now, this, to some extent, access to this technology it seems natural to think that it modifies a little bit, to the extent that it can, the biological clock of women. It potentially alters, therefore, women's choices on fertility, age of first birth, education choices, career choices, and so on. Now, what I'm going to be focusing on today is in the determinants of IVF success. So it seems natural to think that if woman A has a higher probability of getting a child through IVF than woman B, the choices done by these 2 women might differ accordingly, potentially delaying if there is a penalty or a premium of doing so. So I'm going to be focusing on the determinants of IVF success today. Now, what determines IVF success? If you look at the prognostic factors by the medical literature, I can name some. There are going to be many. Ovarian sensitivity, chromosome competence. There are going to be a bunch of factors. I'm going to show them later. If I put them in a box, it looks like success is going to be random, right? There is little choice in those factors. Now, the fact that these factors actually matter and they are relevant for IVF success doesn't mean that other factors are not. So once we do what we do, hopefully I convince you that success in in vitro fertilization is not random. In particular, I'm going to emphasize that mother's education is going to matter, okay? We try to destroy this, turn this down in many ways, we just couldn't. There's going to be one way at the end that I'm going to show you that he gets there, but he gets there in terms of explaining it rather than destroying it. Okay, so this is going to be the case for every phase of the IVF treatment. starting with the egg retrieval, embryo transfer, and ending with live birth. Yes?
Isn't there a first stage of selecting the average?
In the first stage of?
Selecting to have the treatment. Where mother's education probably plays a big role.
It does. So I'm going to have a Heckman selection model to address some of that. It's going to be also positive. So the gradient of more educated women are going to jump in this technology more, which is consistent with a lot of health research as well. Now, given that they jump within, having already been in the process, the education gradient is still persistent. This is going to be robust to anything that we could throw at it. Infertility causes, we have them all. Health status, visits to general practitioners, diagnosed diseases up to the ICD-10 codes. Also health behavior for at least a part of the population. We're gonna know if they smoke, they drink. Health clinics, so we're gonna know exactly which clinics they go to so we can control for clinic fixed effects. Labor outcomes, income, wealth, spouses are gonna matter a little bit. And so on. But nothing is going to really distort the fact that education, the mother's education, seems to be relevant for IVF success. Okay, so let me show you some numbers just in case I don't get to the end. So I'm focusing on Denmark. It's going to be 95, 2009. I'm going to be looking at the education gradient, basically dividing education in 3 categories. It's going to be less than high school, and then college and above. Later, I'm gonna give you a finer definition of it, or even we can go with the schooling years. Nothing is gonna change. So with respect to average, individuals with high school degree are gonna have 13% higher success. Okay, the average success is gonna be around 23% in the first treatment. So all the numbers that I'm gonna show you are for the first treatment. Then later, I'm gonna show you the effects for across all treatments and overall. With a college degree, mothers that have a college degree show a 22% higher success. Now, the whole talk is gonna be about this. So I'm gonna show you just data on this. There is no fancy identification strategy. This is gonna be a linear probability model, but on the right-hand side, I have IVF success, 0, 1, live birth, and on the right-hand side, I'm gonna have a bunch of things. Okay, and I'm gonna change that over time. Yes?
Question about percentage point or percent. So you said the success is about 20-something%. So for college degree, 22% higher goes back to 25.
20, yeah, exactly. So 22 of the 23. Yeah.
Okay, so a quarter of it.
Yeah. Yeah. Okay, now what explains this? So we found it. So now what? Okay, so what explains this? I'm gonna look at public clinics. I'm gonna discuss all that later, but I'm gonna rule out financial constraints to the extent that we can. I'm gonna rule out, potential stories that, we may think that could explain this, at least all the ones that we could think. And what we are left with is things that we do not really observe. So the IVF protocol, I'm gonna show you it's rather strict and complex. I'm gonna have to read it to somehow make sure I get it right. So it's gonna be, strict and complex, and a lot of the things that women have to do through this process is not going to be observable. So I'm going to have to do with nose sprays they have to put, I'm going to have to do with injections they have to at home, tablets or gels. So these things are not done at the clinic, and therefore we cannot see whether they happen or not. So there is a potential story behind this success, higher success of educated women, which is they are able to follow the protocol a little bit better. Okay, that would be a potential story. Another story would be a story of psychological factors, with perhaps more educated women are able to deal with stress or all the situations that they have to face when going through this process, which is a pretty stressful one. So I'm gonna have those 2 factors as potential stories for it. For that, I'm gonna, and I will be brief about this because mostly when I'm gonna talk about one, I'm gonna build a small model of IVF treatments where women are going to decide whether to go into treatment or not, and for how many treatments they go. Okay. The productivity efficiency, or that self-management or ability that women have to follow the protocol, is going to be depending on education, and also the psychological factors that potentially affect these outcomes is going to be also depending on education. So trying to match success rates across treatments and dropout rates across treatments I'm gonna find the properties of these latent factors on productive efficiency, which is called, it's what I'm calling self-management, and psychological factors. Now, this is a, yes?
I have a question. So this is after you control for marital status, like if they're married, the education of the husband, if it's the first baby or the second, or
I'm gonna be controlling for all that, and this is gonna be focused on the first baby. So yeah, on the first baby together, because the law allows them to have another baby with separate couples, yes.
Just to better understand the context, so how is IVF treatment covered in Denmark? Is it covered by health insurance? And are there health insurance differences between?
So I'm gonna be focusing, I'll get there, I'm gonna be focusing on the first three treatments, which are free in Denmark. So most 85% of all the treatments that we're gonna see are gonna go through the public system. I'm gonna show you differences between the public system and the private system. So everybody goes through the public, and then you're gonna see that the people that go through the private, the success rates drop, okay? Because it's already people that went through public and did not succeed, okay? That's important because it's gonna help us roll financial constraints, at least for the first three treatments. Okay, now, this story could be made up, right? I just have a story on something that I do not observe. I have a model. I'm gonna match things that I see in the data, but I do not directly observe how women self-manage in terms of taking the right dose of whatever they have to take at the right time. And I do not observe either from this data set psychological traits. So what I'm gonna do then is come up with proxies that potentially have a bit of both in order to give a little bit of support to the story that we have, okay? So the proxies that we're looking at are gonna be, and we tried many things that, I can talk a lot about this, but we ended up basically choosing two of them. One is for a subset of the population, we managed to get, for those that finished high school in recent cohorts, we managed to get GPAs. So to the extent that GPAs might measure the ability of self-management, in a set of general skills, and also might reflect potentially psychological factors, if they are hopefully correlated with the same thing that women go through in IVF, then we might have a little bit of a story in terms of what determines this B, the productivity, the psychological factors, and this productive efficiency. Indeed, when we run these first regressions with GPAs, then we kill the education gradient. So GPAs basically are going to absorb everything that was going through education. Okay? Yes. Yes, sorry. Yeah.
Yeah, my question was about whether you have considered any psychological factors, so like community level effects, basically saying like from various point where college degree women are going to be more likely to select into IVF. They likely might know people who have done this before, and that sort of like community of knowledge maybe is something that helps follow the protocol better aside from other constraints.
That could potentially, the way we're going to go about it, which is the only way that we thought, well, the only way we could look at it in the data is we want to look at health clinics and distance from home to health clinics. To the extent that that implies that the whole neighborhood or the people living in the area are subject to, the same exposure, that I think goes in that line. But it's not that we directly have a network that we can assess. But I think it goes in that direction. Yes.
Kind of come back to whether it's just health selection, basically. Have a more educated women, basically, or couples starting it earlier, and therefore, on average, more healthy and relevant to women. So health selection, basically, the argument is health selection driven, with selection on health. Now, people wait for differential time before they start this treatment, and as a result of community effects or knowledge, basically the more educated started earlier and have a healthier composition, and that drives all of this.
The more educated actually start later, a little bit later. Now,
but that's not. But you're controlling for age.
We control for age, of course.
So exactly. So it's conditional on age. Are they healthy? Right?
But
so,
are you looking only at first birth?
I'm going to be looking at first birth through IVF, which is mostly first birth for women. Yeah.
Yeah. No. Going again, the selection. Like lower educated women have a first birth younger, so you're gonna the selectivity of the lower educated, you're going to end up with those who are unhealthy. Because if they were healthy, yeah, I'm again thinking about the selectivity processes. Yeah, I mean we have lots of
I think it makes sense. So I think to the extent that we can, we clean for that because we're going to have all the infertility causes that are diagnosed by the doctors. So we're going to control for them, including males, including the partners, male causes. So I have all the ICD-10 measures, so I know, all possible diagnoses that have been run through, for this population. Is that enough? Hopefully it is, but yeah. Yeah, so we control for that. Hopefully I get to show you a bit of that. Okay, now what I wanted to say as well is that these GPAs not only help determine the success in IVF, but interestingly, it also helps determine post-IVF outcomes. So anything that goes post-IVF seems to be wages, labor market outcomes that I've been looking at, are also be potentially determined, are also going to be determined by GPAs. We're going to see at the very end, if I get there, motherhood penalties by GPAs, okay? And there are substantial differences. Okay, so hopefully I convince you there's a gradient. There is a story coming through structural setup with some empirical support coming from GPAs and also pre-IVF wage fixed effects, and I'll talk about that in a bit. Okay, so related literature, a lot of literature, in particular literature on education and adoption of health technologies. We're going to show an education gradient, again, through the selection model in adoption. So more educated women are going to jump into this more in success and in dropout rates. So basically all through the process. Then this literature is also related to a couple of papers, one by Colin Loughy and Wharton, that basically looks at the effects of IVF access on pre-IVF outcomes. We are not going to look at that, but we are more directly related to this paper at Lundborg et al. That use IVF outcomes as random and therefore as good IVs for understanding the effects of children on labor market outcomes, right? So in our case, we're going to show that, well, it doesn't look like it's random, okay? With education, GPAs, pre-IVF wages. Okay. All right, so let me give you a little bit about the institutional context. Women need to be 45, not more than 45 to go through IVF. They need consent of the couple, at least in Denmark, man and woman being treated. And in the doctor's opinion, they need to be suited to have a child and taking care of the child, both mentally and physically. Now, in addition to get the free treatments, they need to be diagnosed as infertile. So this is, you can get it in the private sector, okay? You need to be diagnosed as infertile. So you need to show the doctor, you have kept trying at least for 12 months. Women cannot be older than 40 at the beginning of the treatment. So it's a, slightly lower cutoff. And they cannot be joint children for the couple. So it's gonna be the first time that the couple has a child, okay? They could have had children before from separate marriages, from previous marriages.
So single women cannot get the procedure with
now they do.
Now they do.
Now they do, and we see in the new data, we see some of that. At this time, we didn't. Sweden, for example, doesn't, and some Swedes actually cross the bridge to Denmark, solo mothers to get the treatment, yeah. Focusing on couples, yeah. The protocol is strict and complex. First, you need to be diagnosed infertile for the couple. Then there's gonna be egg retrievals. And for the egg retrievals, the aspiration, women are gonna have to do a lot of things. So first, downregulate the follicle stimulation hormones. That implies 2 sprays every day, 1 spray twice per day at the same time, and a different spray 4 times per day at the same time. Then that's basically to not overstimulate the ovarian stimulation that comes next, which implies an additional nasal spray, also apply 4 times a day. This can be substituted by injections in the belly, usually once a night, okay? And then at the last day of the stimulation, you also get an additional injection. They need to put an additional injection. At the same time, all this is monitored with regular visits that you need to show up to the visits. All right, so 3 to 5 regarding blood tests and ultrasound tests. Okay, then once the eggs are retrieved, well, in order to retrieve the eggs, you're gonna get an injection to release the eggs. That's gonna be 10 days after the stimulation begins, so you need to keep track of all this. It's going to happen 40 hours after the application. It's very important the patient manages to follow that procedure. Okay, so at the time, to take the injection at the time that the doctor has told you to take the injection. Okay. Egg retrieval insemination, this is performed by doctors. And then there is the embryo transfers. It's going to take basically 2 or 3 days after the eggs have been retrieved, if there are healthy embryos to implant. Then once the embryo is transferred, you have to make sure that, well, in addition to, not to smoke, no drinking, and so on, so that you increase the potential birth, you're going to have, in the 2 weeks following the transfers, you're going to have to put 1 tablet 3 times a day, apply gel twice daily, and a bunch of things. Okay. All right. Okay, so this is kind of a recap of all this stuff. Strict and protocol complex. Let me skip it. This is the data. I'm going to merge IVF registered data, which is going to keep track of the date of treatment, reasons for undergoing treatment, infertility causes, diagnosed, indicator of successful aspiration and transference, so we know what happened exactly at each phase of the IVF treatment. And for some years, we're going to have also health behavior. Okay? Yes?
Are you able to observe compliance?
That's what I do not. Yeah, that's what I do not, because it happens at home. What I know is if they show up to the clinic for the blood test, right? But I don't know if they put the syringe at the right time, they took the pill at the right time, they took it, all days they're supposed to take it, right? So that's, yeah. That's why we go through this latent heterogeneity through the context of a model, and then try to proxy to the extent that we can through GPAs and pre-IVF wage fixed effects. It would be great to have that. It will make our life so much easier. Okay, then we have the regular register data for all the labor market outcomes, and then the health register data, not IVF, but other health issues, including the ICD-10 codes and so on. Okay, so this is the kind of the sample that we have. Women, I'm going to be always looking at less than high school, and college. These are the women that go through IVF. So you see the age of the women is relatively similar, maybe a bit older for college. Proportion of merit is very similar. What is different is income. Okay, so patients with lowest, less than high school are going to have less income than patients with college and so on. And also the spousal income is different. These differences also show up in employment. So a lot of the less than high school women are not going to be in the labor force. That's not the case for the college women. All of them are going to be in the labor force, most of them. You can see here the unconditional success rates, 20.9, 20.4, and 26. That's going to be unconditional and everything. And this is the proportion of them treated in public hospitals. Okay. And yeah. Okay. So I can click here and show you a bunch of, well, let me go through it. So for example, infertility causes, we have all these measures. Plus more, just, these are kind of aggregate, cervical defects, ovulation defects. You can see differences across education do not seem to be there. Maybe for fallopian tube defect, there is something, okay? In terms of health, we're gonna have the general practitioners, the services they go through, also the cost that the government pays exposed to the doctors. Health status, we have the ICD-10 diagnosis. Here I just show you 10 of them, but there are hundreds. Okay, so we control for those. Circulatory systems, respiratory, what and what not. And then in terms of health behavior, this we only have it from 2006 to 2009. So for that sample, we're gonna have BMIs. We're gonna have the amount of cigarettes they smoke per week, and also the amount of alcohol they consume per week. Okay, so for example, here you see differences across education groups. More educated groups smoke less and drink less. Okay, important to control for that in the last phase, at least. Yes?
So, do you know if these are like native gays or if they're immigrants or?
Oh.
I find BMI more than 30 for less than high school, like almost 16%, really high for Danes.
That's a good question. I don't know. I will have to look, but that's a good question. I maybe use it. We maybe use that variation for something. I didn't think about it. Yeah. I'll look into that. Yeah. Thanks. And this is private sector and public sector success differences, just to give you a hint of it by age groups. you can see that the public sector always does better than the private sector, except more than 40, because there are 0 women going to the public sector with more than 40 years of age. Okay, so hopefully I convinced you that we have a rich enough data set to do this, at least as a first stab at it. So this is going to be the linear probability model that I'm going to be pursuing. This is an indicator, 0, 1. If a child is born, it's going to be 1, 0 otherwise, coming from IVF. For a woman I, in treatment J, health clinic H, at point in time T. I think I got this right, hopefully. So here you have time fixed effects. So basically to control time trends, maybe improvements in the technology. Here you have health clinic fixed effects, which is important too. Maybe some clinics have better doctors than others. We couldn't find doctor fixed effects, but it looks like in the public system, you're going to be seeing basically every doctor in the clinic. So you're going to have individual characteristics here, some residual. And what we are interested is in this schooling variable. So we're going to have, this is a dummy that takes 3 values, high school, less than high school, and college. Okay, so I'm interested in that alpha. Okay, so let me run this with all the data that we have. First specification does not control for anything except for a constant. So this is a linear probability model, so that implies that the benchmark is going to be less than high school. So that implies that with a high school degree, you're going to get 4% more success than without it. And with a college degree, you get a bit more, close to 6%. Then we started to control for age dummies, for time dummies, and health status. Here, health status incorporates everything. So all the ICD-10s, practitioner visits, and so on. Socioeconomic characteristics, of course, infertility causes, of course, and then clinic fixed effects. Okay, so at the end of the day, the one that we pick as benchmark is gonna be number 5, that has all the controls. And you're gonna see that, basically the results stand across the specifications. It's positive, and it's, a bit larger for college than for non-college, than for high school. Okay.
Is the difference between high school and college significant? The difference between high school and college.
So here it's not, but here it is. Yeah. So once you control, here it is. If I have time, maybe I show you, what happens also with masters and PhDs and high school dropouts, and then the differences are going to be enlarged. Yeah. Yes.
Do you have any data on successful having children naturally conceived after failed IVF? So, there's, I guess the concern is that I've seen somewhere is there concern about overuse of IVS. Is that driven by impatience in places that make it very readily available at low cost? And so, while it may initially be counterintuitive, there is a sizable fraction who actually conceive naturally after failed IVF. And so anyway, I was wondering, that would be partly allow you to get a selection of certain differences.
I'm sure we have the data, so we should look at it. Yeah. Thanks. Yeah. I think at some point we ran this for people for which this was not only the first IVF child, but also the first child. And it looks to me that nothing instructs us to change anything. But we should look into that. Yeah. Thanks. Okay.
And so to what extent do you think education might work through health status, socioeconomic characteristics? And if so, why do you want to control it?
It works, yeah. So here, I would say not so much, because this is not really behavior. One may think this is not really behavior. When I include now smoking and all that, then potentially there are mediation across the two.
The outcome of all those processes.
Yeah.
And education might affect all those processes.
Indeed. Indeed.
So should we just look at columns 2?
Column 2?
Right. I mean, the difference between the coefficient of high school in column 2 and column 5 is
Yeah.
a fair amount.
Could be, yeah, that's true.
But
For
column 5 may be because education is working through health status, socioeconomic characteristics.
might be a little bit. So, but if I take this number or this number, you see the standard error, and this one, it's not super different, but certainly, everything is going to be related. I'm not making claims here. Yeah. even though I'm calling these determinants, education as determinant, yeah. As I said at the beginning, no fascinating identification strategy today. Yes?
Do you know the difference in fertility rate is in the population by education level? Just in the general population. I'm wondering if, is the fertility rate higher among people who didn't finish high school, who finished college, and then just the general population?
I think it's a little bit. I don't remember the numbers. There must be somewhere in the paper. I would say so.
I'm just interested in obviously control for selection, but if there is somewhat of a different selection process.
Yeah, I think we all have the same concern. So hopefully what we did with the health clinics is at least goes in the right direction, hopefully, yeah. So let me get there. So I'm gonna keep looking at the finite education gradient thing. These are the back of the envelope numbers that I shared at the beginning, computing it with respect to the average. So 13 and 22, okay. This is what you get by phases. So if you look at the egg retrieval versus the embryo transfer versus the live birth, and then live birth controlling for 2 embryos transferred, so maybe potentially more than 2, because that also increases success. And it seems to, there are different degrees, different numbers, but it seems to exist across the border. Okay. Now let me do robustness on what I think I can do, which is not too much regarding what Jada said, which is let me actually look at something that potentially does have some behavior coming from education. Financial constraints, I'm gonna look at occupations too, because some of them might be more difficult, more physical, and therefore have implications for live births as well. Partners education, selection into IVF treatment, and non-stationary. I'm gonna look at some of that. Then, after looking at the first treatment, I'm gonna look at the overall IVF success, looking at all the treatments, and not only the treatments, but also the dropout rates. Because certainly there is selection in, but there is also selection out. Okay, so we're gonna look at both. So this is kind of a table that makes all that, okay, regarding the first treatment. So this is the benchmark table with all the controls, including infertility causes and so on. Once you control for BMI, smoking, and alcohol, numbers do change. Now, these guys boost up a little bit. The gradient stays. If you control for wealth, this is wealth before IVF, right? Also, when I was talking about labor income and employment, obviously it's before IVF. So it's positive, but it doesn't alter the gradient. Occupations, fixed effects, it doesn't alter the gradient. And once you control for the fact that you have a partner with a high school degree or a college partner, the partner with a high school degree doesn't seem to matter too much. The college partner seems to help a little bit. Okay, not as much as the mother's education, which is going to be larger, 0.4, but some. So in terms of putting things on the right-hand side, we kind of run out of ideas, but we can put more things, maybe.
Do you have a age at union formation, or if you think that people start looking for a kid when they form a union, and do you have that information to see if it affects?
I think so. For the couples here, yes, I should, because they have to register as couples. So it could be married or cohabitating. So I could look at that actually. Yeah.
It could be that people who have married late, and so they start looking. It can affect that.
Yeah, I'll remember all these things that you guys are saying. Yeah. Okay. All right. So now selection into IVF. So let me show you first the IVF women that we have. Then we look at all the women that are potentially IVF but do not go through IVF. So this is like 1 million people in that sample, in that particular set of years that we have. Okay, so there are differences, but nothing that really jumps into, wow, there's a striking difference between the two in terms of high school, in terms of education, in terms of age. A little bit more of them are married, but they need to be married to go into IVF. They are a bit richer, but not substantially. And yeah, okay. So now what we did is kind of do a selection, HEMAC selection model, where the exclusionary restriction is going to be the number of clinics in the municipality of residence. So the idea meaning that access is going to be easier for those that have a lot of clinics around. Okay, potentially capturing some community networks and potentially also capturing some potential financial constraints at the same time. Okay, even though the free treatments are there, it might still take some time to go to the clinic. Okay, and time is money or something like that. So you can see that in this case, the numbers are still there. Now, this is not, this is for the participation, sorry, that's what I wanted to highlight earlier. So there is definitely selection in participation. So the more educated you are, the more you go into this new technology. Now, conditional on doing that, given the exclusionary restriction and so on, these numbers are still there, okay? Not super significant anymore, but you know, the study's there. Okay.
This is
Yes.
conditional on age.
Yeah, it's conditional on all the controls, full controls, age, medical, anything that we could find. Yeah. So conditional on all the controls. That was the first treatment. Now, overall success is going to be a matter of the number of treatments, right? So, and also whether you keep going. So we're going to show you access, I mean, some numbers for that. These are the numbers, live births, IVF success by treatment from 1 up to 5 and then to all. There are more than 5. There can be also more than 5 in the public sector because a definition of a treatment that counts is going to be one that actually has one healthy embryo. So you can actually go through the public system many more times than 3. Okay, so we have a woman, I think the max is 19 that we have, but obviously an outlier. Okay, so you can see the gradient happening everywhere across all the treatments. You know, here we lose a little bit. If we take all, you know, the numbers are similar to the first treatment. You can see the accumulation, right? So the observations are dropping. So there is less and less women going through that. Okay. So what is the selection of dropping out the treatment? Obviously, there is selection because you know some had a baby, right? So if the more educated had a baby, the less educated are going to be populating a bit more the next round, right? But is it the case? So this is exactly the same regression, but now in the left-hand side, instead of having IVF success, what I have is dropout rates. So whether they drop or not. 1, they drop, 0, they don't. Okay? So you can see that women with college, after the first treatment, drop out less than the benchmark. The benchmark is again less than college, less than high school, and also high school drops a little bit less than less than high school. This stands in the first treatment, so there's going to be selection moving. There is selection entering, and there is selection moving forward. Okay, so it's going to be in the second, the third, the fourth, fifth, and basically, you know, an average and all. Okay, so that partially explains this. Live births for all treatments is a mixture of the two. It's a mixture of the gradient by treatment times the population that keeps going. Yes.
So if someone dropped out because they were just no longer doing the treatments or anything, or whether or not, like Jared said, like that there was a successful natural birth. I have friends who, you know, went through the egg retrieval, and before the embryo transfer ever happened, they got pregnant naturally before that happened. So that's like a different type of dropout than someone just stopping to
I could look into that. I guess I would know, yes, yeah. Because I know the live births through the civil records. Yeah, so I think I should know that, yeah, too. Yeah. Yes?
Do you know whether they had the egg harvest every time? I mean, were their eggs preserved, and were there differences across the educational groups as to whether they had to go through egg harvesting to get an implantation?
So I don't remember. I should know, but I think we looked a little bit into this. So it seems that freezing, if that's what you're thinking, is something that is more recent than in the early 2000s, but it's something that it's happening. And I wouldn't say, yeah, one of our co-authors went through that as well, given what we learn about the odds.
Do you know the number of embryos the number of transplant eggs you had that you could plant?
Yeah, we know the number of embryos, so we control for that. It could be 2, 3, and so on. So we that we know, yeah. But I think in this period, I'm not sure if we're able to distinguish whether they were frozen like some time ago when when they were younger, or they are just, from the current year. But I think we could know, yeah. But I don't think that's a big phenomenon in the early 2000s.
The number of eggs embryos produced from the harvesting by education?
I don't remember.
Because I'm wondering if that shows something about the process that you went through beforehand.
Yeah, I don't remember. I think me and my co-authors would know this. I don't remember. I remember a discussion about it. Sorry, but yeah. But I'll ask. Yeah. Okay, so taking a stock, hopefully I convince you that IVF success is not, pure luck. It's not purely idiosyncratic. There is some other education gradient. We throw things at it and it's there. Now the question is, what explains the education gradient? Well, in some sense, by running all these regressions, we kind of rule out financial constraints or allocative efficiency stories, in the sense that maybe the more educated have access to more resources than the less educated. First of all, we are looking at the first treatment, and that's public. Controlling for distancing in health clinics as well in the selection. We control for income, we control for wealth. So it's hard to imagine that that's the main driver of the gradient. Also, we control for confounding factors that potentially explain also that, and they don't seem to bite. So what is left for us is, things that we do not see. Okay, so we do not see, how much they comply, how much these women comply, and if there are differences across education groups. Okay, so for that, let me tell you in 3-4 minutes. What we do is we set up a model, an economic model in which women are going to be choosing whether to continue treatment or not. I'm not going to be modeling selection into treatment. Women are already in treatment number 1, but they have to decide whether they keep going or not. Okay. So that's going to have, we're going to have basically 2 sources of heterogeneity for women. One is basically the ability of self-managing. That's what we call productive efficiency, the skills that facilitate that acquisition and processing of the information needed to follow the protocol. Okay, and then some personal traits that potentially capture coping with stress, maybe resilience, grit, something that gives you more perseverance than otherwise. Okay, in this. We do not see that. That's why we set up a model in which these 2 factors are going to be latent. We're going to recover the distributions of these 2 such that we match the success rates by treatment and the dropout rates by treatment. Okay? And we do that. For example, let me give you just 2 slides of it. This is kind of the environment, and then I give you the problem that they are solving, and then I'll show you results. So these are women that are already in IVF, but they need to decide whether they continue or not. They're going to be up to 6 treatments. This is the first child they have. Each individual is going to have 2 permanent factors that make them different across individuals, which is this IVF productivity, self-management, and psychological factors B. These distributions are going to differ by education. Then the probability of success is given by this logit function, that it's affected by both, by your self-management, and at the same time by psychological factors. And B can be positive or negative. So some women are going to be better under stress, some women are going to be worse under stress. Okay? Potentially we give that freedom, that non-parametric freedom to the distribution of B's. Okay. So the main trade-off is that, well, if you want to continue, you're going to pay a psychological cost, that's stress, but you're going to gain the probability of having a child, and in this case, the individuals here like children. So let me give you just one decision, and then I'll show you a bit the results. So this would be the case of a woman that doesn't have a child and is deciding whether to continue or not. So N0 is no children, it's a treatment T, and it has this combination of self-management and psychological stress. Today, she doesn't have a child, so there is no savings here, so basically you eat your income. This is the disutility cost of going through treatments. That's the psychological cost, which can be positive or negative in the production of the child, but it's always negative in utility. And then what you get is, well, what you lose is that you go through this cost if you pursue the treatment. What you gain is the expectation of having a child, and the expectation comes from this probability, or not having a child, and then you are stuck with N0, and so be it. Okay? So these women are choosing whether to stay or not, subject to this. Okay. So these are the targets that we have, which is exactly what I showed you before, by treatment success rates and by treatment dropout rates. We estimate this. Okay. Hopefully you believe I can do that. And then we compare data and model. So this is the number of treatments. These are the dropout rates. So in blue, you have the data for different education groups. These dots is less than high school, thick is college. So you can see the dropout rates by treatment for the college are always lower than for the less than high school. Okay, the model is in orange. So it kind of gets there. It doesn't get all the way, but it kind of gets there. Okay, in terms of dropout rates. Obviously, the dropout rates increase. That's what we saw in the data, increase with the treatment. People become less and less perseverant. Okay, but the education gradient persists across treatments. Yes?
So on the Z and B, are there a set of indicator variables to predict these latent variables?
So C and B, they are continuous variables, and what we're doing is recovering the distribution of them, such that we recover this. So I think we have, I don't remember if there's a grid of 10 of each, 10 Cs, 10 Bs, maybe. Yeah. Okay. And then for success rates, it's the opposite. Success rate goes down with the number of treatments. Okay, potentially women entering are the less physically fit as well. And you can see the success rate in the data is blue, going down for all education groups. Still higher for college, lower for less than high school. And the model is the orange, and it kind of gets there. Okay. So now, given that we have the model, we can decompose how much of the success rate might come from productivity versus psychological factors. Okay, and that's what we do. So I do that decomposition, and you can see this is the case where I give the less educated the productivity of the high educated. Okay, so in that case, all of them collide close enough to the success rate of the data that we have for the college women. So productivity explains a lot of the success rate. The psychological factors are going to explain a lot of the dropout rates. Not everything, but a lot. This is when I give the level of psychological B or stress or factors of the college-educated women to all the women. Okay, and obviously they are still different in productivities, so the dropout rates are different, but they get closer to the solid blue line. Okay, so psychological factors, they seem, at least when we match this simple model to the data, explain a lot of the dropouts. So they help you either to persist or not, and productivity explains a lot. Given that you are in a treatment, explains a lot about the success. Not everything, but a lot. Oh, I did this by education. So this is high school, college, and less than high school. I didn't do it by GPA. I could have done it by, looking at the data by GPA. Let me use GPA now, though. So I just used the model to recover something that we do not see. All right, that seems to validate, or seems to be a story, potentially a story for the education gradient that we see. So I was focusing on the education gradient. Now, I would like to have direct measures of C, direct measures of B, but I don't. So the best that we can do is, well, let me proxy for them. And the way we're going to proxy for them is going to be using GPAs. And it's also going to be using, alternatively, the fixed effect of the wages of these women before IVF. So in principle, capturing also ability. GPA is going to be capturing ability of self-management in a different context, school. The fixed effect is going to capture that in a different context, work. This is a different context, which is, you're going through IVF. Now, potentially all these are correlated some way. Okay. Limitations clear? Okay. All right. So we don't have direct measures of that. So I'm going to proxy for C potentially mixed with B, which is going to be, using these two alternatives. GPAs for a subset of women with high school degree. These are going to be cohorts below 35. So the sample is going to reduce a bit. And then fixed effects of pre-IVF wages. So before you go into IVF, I know your wages. I compute a fixed effect. I'm going to say that's a mixture of ability and psychological factors. And I don't attempt to disentangle it. Okay? The same thing with GPA. Again, schooling context, work context. We are after health context. Hopefully, they are all related. Yeah. Okay, so can GPA determine IVF success? So this is success rates, and these are dropout rates. Okay, so I'm these are all the full controls, but I don't put, the tables now is shrinked. So I'm showing you the college, only the college, because this is the GPA sample. So I do not have the people that did not complete high school. So I only have high school and college. So you can see the gradient there. This would be the benchmark regression for that, college. That's a college coefficient. Then once you control for GPA, that's for the first time we kill the gradient. Okay, we kill the gradient. Now all that seems to be absorbed by GPA. Okay, so the ability, this measure of ability that or self-management and psychological traits that explain GPAs potentially also explain IVF success. Okay, so whatever is explaining GPAs, it seems to carry some weight into explaining potentially IVF success. The same thing with dropouts. Remember, more education implies less dropouts, so you persist more, which in the context of the model, that was being carried by the psychological factor. Here, I don't know which one is carrying it. It's a mixture of the two. You control for GPAs, it kills the gradient, and then everything is absorbed by the GPA. Okay? So it does seem that a story of these unobserved factors that potentially determine productivity and psychological traits might be a good story behind the IVF success. Okay. Again, it would be great to have direct measures of both of them separately, which is done. Now, GPA determines IVF. I can show you the same thing with the pre-IVF wages, the fixed effects. Okay, but I don't. Now, just for the last thing that two things that I want to show you. So hopefully I convince you there is an education gradient. And if I look at a subset of individuals for which I have measures of ability and psychological traits that might be good enough with GPAs, that explains the gradient. So it's nothing, it's a bit far from being just random or luck. What I'm going to show you now is that what determines IVF success can also determine post-IVF outcomes. So it can also determine wages post-IVF, right? So using IVF success as an instrumental variable to see the effects of children on labor market outcomes might not be too kosher, okay? So this is, I focus on women that succeed. So first I'm looking at the sample of women that succeed. Okay, looking at the women that succeed, what happens to their wages 2 years after IVF? What happens to potential explanation of wage changes, like switching firms, industry switches, occupation switches, 3-year periods, 10-year periods? We tried several things. You can see that college matters. Obviously, it explains still wages after. And GPA matters. Not only matters for wages 2 years ahead, I can show you this 10 years ahead. It matters for things that we think might be relevant. You might be thinking about occupation switches, moving from part-time, full-time to part-time, or from non-children occupations to more children occupations. So all these occupation switches are going to be there. Okay, so these things matter. It doesn't seem to matter for the 3-year period here in the occupations, but it does matter later on. Okay. So this does not only determine IVF success, it also determines what's going on afterwards. So, there's an endogeneity here that in order to assess the effects of children might be troublesome. Okay, so GPA determines both IVF success and post-IVF labor market outcomes. I can show you the same thing with the pre-IVF wages, okay, the fixed effects. Yes, so in this yes. Yes, sorry, I should have explained that. Yeah, yeah, sorry.
More flexibility in those jobs?
Potentially. What is relevant for, you can see here, sorry. What is relevant for us is that it explains, it's interesting to see that it explains the IVF success, and at the same time that it explains, perhaps not surprisingly, if you're looking at GPAs, it explains the wages afterwards. Okay? Now, if you do the same thing with the wage fixed effects, pre-IVF, they will also explain IVF success. So that, those fixed effects ex ante before IVF carry information on ability and psychological traits that also carry for labor market outcomes afterwards. Okay? So there's a lot of endogeneity here, which we do not attempt to disentangle, which is putting it out. Yeah. Yes.
No, just
yeah, I'm good. So this is another slide, and then I go.
Can you go back to the GPA effect on IVF success, the previous one?
This one.
This one, the ends are different because you're saying you're selecting a smaller number of observations.
Oh yeah, you mean this? Yes.
Yeah.
So they are.
So what happens if you just run the overall the one regression on just the 6,600 subsample?
So we have it. Yeah, we have like this. So I have it in the paper. This morning I just cut it.
Oh, okay. You still okay?
Yeah, but yeah, it's there. Okay. Same thing for the fixed effects, post-labor market. Okay, and then let me just finish with this, which you can see it's, it's from this morning, just kind of deciding how to wrap up the paper, if we can say something else or not. So maybe you have ideas on this. So here what we did is, I just show you IVF success is determined by GPAs, education, fixed effects. Also post-labor market outcomes, even focusing within the women that have success. You can do the same looking at women that did not succeed on IVF. Then you're gonna see also GPA also mattering for differences in wages and so on. So here what I'm doing is, I'm looking at the motherhood penalty. So I'm looking at success and no success in IVF, okay? So if you run the standard regression, you're gonna get, at least in this Danish data, you're gonna get something like this. So that basically means a horizon, the first 2 years, basically means a horizon from 2 to 5 years implies a drop in 1.7% wages. This is the sample of full-time workers. Okay, so these are women, we can change that. This is kind of first thing that we looked at. So you can see the drops, okay? So motherhood penalty here. Now, where we're looking here is different GPAs, low GPA, medium and high GPA, and then different fixed effects, just to make things a bit more complicated for you. So fixed effect 1, low fixed effect, high fixed effect, okay? So just look at the 2 to 5 years, which seems to be the one that gives the highest bite, the largest bite. You can see that, it seems to matter quite a bit for GPA 1 and low, but it matters a lot. It seems that, part of the variation, a large part, is gonna be driven by the highest skilled women, high GPA, and also high fixed effect. These are women with high GPA and high fixed effect. When you look at, nothing really happens first 2 years, 5 to 10 years. These are wages, full-time workers. So this is not the standard numbers that I used to see, which is like women change to part-time, therefore labor income comes down and so on, okay? These are full-time workers, these are women. So you can see that, at least in this context, there is substantial variation of the motherhood penalty across GPAs, okay? Which I think, again, enhances the evidence into the fact that these factors do matter, okay? In a manner that we cannot consider just random or pure luck, okay? Thank you.
Technically, we're out of time, but some quick questions.
So there's this conjecture that fertility drops with the mother's education. The more educated women have lower fertility, unless they keep the religion, and then religion compensates, and then they're more fertile. And I wonder if you have any kind of religion indication that you control for. And the general question is, how do you reconcile that? I mean, how we explain that more educated women want more children, with this conjecture.
So I control for it by not controlling for it.
Right.
So I should control for it. So I think
Would you have
I think so.
Is it from the
I think when
clinics that you get the demographics?
yeah, it has to be from the regular register. If there is religion, I will ask, but it would be
Registers don't have religion.
the regular registers. They might, huh?
In Denmark.
I think they might here. They will have migration, so that's not religion, but.
John, you get the final question.
Thank you.
So kind of a separate study, but given you have access to registry data, could you look at the number of children per household in like the neighborhood that people are in? Because I'm curious about thinking about kind of peer effect. Not for this paper, but it'd be interesting if success or lack of success might be a function of how many kids are living around. Like the stress level may be higher, for example, if you want to have kids. Your neighbors have kids versus.
That's nice, thanks. That would be one observable, perhaps, that can help me get at the network story that was out there. Yeah. Thanks.
Okay, we're out of time. Thanks, Raul.
Thank you.
Porque yo tengo tantos amigos que están con este libro, todo así. Tengo mi sobrina que lo está haciendo, todo, así que estoy...
No, tenemos una coautora, la joven, que ha congelado los huevos. Una vez se enteró de las odds.
Pero ahora, porque ahora te iba a preguntar eso, porque ahora ella está arrepentida.
Bueno, que 2 minutos.
Thanks a lot for the comment. Thank you so much.